Action.
Ready? Okay, guys, today we're going to talk about sepsis. Before I talk about sepsis, I first have to talk about SIRS, and that is Systemic Inflammatory Response Syndrome. To break that down, it just means systemic means your whole body is going through an inflammatory response. Sepsis is one of those situations, but it's caused by either a bacteria or a virus, most often bacteria in this situation. So let's talk about sepsis. We have the infection. It's going to damage tissues. It's going to start inflammatory mediators, and we're going to start the inflammation process. Inflammation process is redness, heat, swelling, pain, loss of function, and this bad boy, vasodilation. Got to keep that in mind. Another thing that's going to happen from this damaged tissue and inflammatory mediators is it's going to release cytokines. Cytokines are just a polypeptide chemical marker, biomarker, and it's just there to communicate with other parts of the body. At the same time, leukocytes are going to go to the site of the infection. Those are your white blood cells coming to fight off the infection. And they too are also going to release cytokines. These cytokines are then going to travel through the body. They're going to go to the body fluids, bone marrow, hypothalamus and brain, hepatocytes of many places. When it hits the body fluids, we're talking about vascular, interstitial, or both. That's when we start entering into this SIRS. See, if we have inflammation, or an infection, say in your thumb, and it stays in your thumb, we don't have to worry about it as much, not a big deal. But once it hits the body fluids and starts going throughout the system, and we get the systemic response, that's when we have sepsis, and that's when we have SIRS. All this is going to do is increase the body demand for energy, so we're going to need more oxygen and glucose. We'll be coming back to that. Let's talk about when the cytokines go to each individual spot. When the cytokines hit the bone marrow, primarily talk about the red bone marrow, it's going to initiate leukocytosis. That's going to be the creation of white blood cells, and leukocytosis is when we have more than 12,000. And we can also see leukopenia. So this is going to be when we have less than 4,000, and that's going to be if the infection is in the bones. Now, one of the hallmarks that we look for is leukocytosis. But just because we have a low number, don't discount sepsis. We could still have that situation. Moving on to when the cytokines hit the brain and hypothalamus. When it's the hypothalamus, it's going to have the hypothalamus release prostaglandins, which are going to communicate with neurotransmitters, and they are going to increase your temperature set point of the body. This is what we know as a fever. Fever? Febrile fever. It's going to be a fever. Reason being is the body can fight off bacteria much better at a higher temperature. Bacteria don't like the higher temperature, and that's why the body goes into a fever. Fun point on that, sometimes you don't want to lower the fever right away if it's not life-threatening because the body is actively fighting and we want to help it. When the cytokines talk to the brain, this is when you're going to get this list of ailments: somnolence, malaise, anorexia, delirium, and hallucinations. This is what we talk about when we say altered mental status of the patient. This is when a patient is going to be confused to person, place, or time because of the cytokines' effect on the brain. Moving forward to cytokines on the hepatocytes. What we're going to have here is kind of a double down thing. Cytokines are going to go through the muscle tissue and it's going to catabolize it. When it catabolizes it, breaks it down to amino acids. This is going to be needed because when the cytokines talk to the hepatocytes, they say, hey, hepatocytes, you need to make acute phase proteins. This needs the raw material of amino acids to create these proteins. So what it's going to do is create CRP, which is C-reactive protein. It's going to create SAA, which is serum amyloid A proteins. And all these proteins are really going to do in this situation is opsonize the bacteria. Now, opsonize, that's just a fun word going back to microbiology where we just flag the bacteria so that when macrophages come along, they say, hey, this guy's not supposed to be here. Let's eat it. And then they can phagocytize the bacteria. Another thing the hepatocytes are going to do is release something called fibrinogen. Fibrinogen, remember, is kind of the netty material that we use for blood clotting. The fibrinogen is going to do something called roulier, which is going to stack RBCs into these little clumps. This is when we get an ESR back, the erythrocyte sedimentation rate. It's increased because of this bad boy right here. So that explains that. Let's go up here for a second where we're talking about increased energy demand. So the body's having a fever, has an infection. It's going to demand more energy. So what does the body do? The pancreas is going to release glucagon, and we're going to get gluconeogenesis and glucose release from the liver and muscles and wherever else it's stored. The body's also going to be under stress, so we're going to have an epinephrine release, norepinephrine and adrenaline, it's all the same. What we're looking at there is more sugar is going to end up getting released, but epinephrine has another function that we're going to talk about here in a moment. Let's put a pin in it. we're going to need more oxygen. The body's fighting, needs more oxygen. So that's why we're going to see increased respiration, increased heart rate. Forget about blood pressure for a second. Yes, that's true. We're fighting fever. We need more of these things. We're going to breathe harder. We're going to pump our blood heavier. But there's another thing that's going on here. Let's go back to the inflammation process and talk about vasodilation. Vasodilation is when the blood vessels get really big and they become very permeable, meaning fluid can exit the vessels, so can small proteins such as albumin. So we lose oncotic pressure, but most importantly, we're losing fluid from the blood vessels. Now, if this has become systemic, that means we have systemic loss of fluids from the blood vessels. No blood in the vessels means a drastic decrease in blood pressure. We have a drastic decrease in blood pressure, it's going to up your heart rate once again, so we're boosting up the heart rate even more. Now, another problem that we're going to have with this vasodilation and loss of fluids is we're not getting oxygen. We're getting hypoperfusion to the distal points of our body and to all our organs and all that kind of stuff. So that means that we're going to need even more oxygen. It's signaling to the brain we need more oxygen, so your respirations are going to increase even more. So that's why when we see a patient with sepsis, they're going to have high respiration, high heart rate, and low blood pressure. Okay, one of the other markers that we see for sepsis is high lactate. Well, lactate is a byproduct of anaerobic respiration or anaerobic metabolism. So we're talking about hyperperfusion. We're not getting oxygen into the system. We're not getting oxygen to the muscles. The muscles are still going to be working, but they're going to switch from aerobic respiration, remember Krebs cycle and all that stuff, to now called anaerobic respiration. Lactate is a byproduct of that. Now, before I talk any bit more, I want to talk back about epinephrine and kidneys. Because I didn't put kidneys on the board, but it's very important to talk about kidneys. We're having vasodilation all over the place. It means we lost blood pressure. We're losing blood pressure to our kidneys as well. When kidneys lose blood pressure, that means that their GFR goes down, and it's going to release renin. Because they want to vasoconstrict, they want to get that blood pressure up, and they want to get that blood flowing through them. The kidneys are getting starved of blood and oxygen right now. So when they release the renin, they're going to vasoconstrict vessels, which is going to decrease how much blood and oxygen they're getting as well. Now, epinephrine does similar things. Epinephrine is going to vasoconstrict gut vessels and dilate body or skeletal muscles. Because remember, epinephrine, we want to run from danger. We don't need to go to the bathroom right now. We can hold the bathroom. So what ends up happening is now we're getting this double damage of vasoconstriction in the gut area, which is decreasing our GFR even more, increasing more renin, and still starving our kidneys of blood and oxygen. This is when we're going to get necrotization of the nephrons in the kidneys. This is also why we're going to see high lactate, because we can't clear out the lactate, also because we have a lot more than usual. And this is also why you're going to get a high BUN and creatine level on your labs. That and because we are hypovolemic. So those two things are going to give you increased BUN. So some of the things that we're going to see with our patient that has sepsis is tachycardia. So that's above 90. That's beat. We're going to see WBCs, either high or low. We're going to see high respirations above 20. Oftentimes we're going to see fever or chills. One of the things we're going to look for is cellulitis or open wounds or Foley catheter or invasive catheters that have a foul smell. That's very indicative of infection. So what we're going to do for treatment right away is oxygen. We need some O2 on this bad boy right away stat. Then we're going to need fluid replacements. Normal saline, lactated ringers. We might even use hypertonic if we have a lot of interstitial fluids and we want to pull back into the blood vessels. We may need to add some more blood products to keep some of that oncotic pressure back into the blood vessels. Drug therapy, we're going to look at vasopressors and, of course, antibiotics. And I believe that is my overview of sepsis.